In the next 30 minutes or so, what I would try to do is to give you some ideas on few rare inherited anemias. Since my special sort of interest is on thalassemia, most of these are the things that I'm going to talk to you today will be rare forms of hemoglobinopathies. And then we will speak about few other conditions as well. My talk will center around 3 cases. So we will do a case-based discussion. This won't be a sort of an interactive session, but I will try to make it interesting and maybe a bit exam-oriented. That is what is probably required to most pediatric trainees. Right. So if we move on to the first case, a 3-year-old boy who has never received a blood transfusion and coming with abdominal distension. You examine him, he's pale, he has mild icterus, and the liver is 3 centimeters and the spleen is 4 centimeters. This scenario is not that uncommon, at least in the hospital where I work, Dragma Teaching Hospital, we quite often see these patients. Because the child is pale, you do a full blood count and it shows low hemoglobin. As I have repeatedly told most of you in several previous presentations, in full blood count, don't only look at the hemoglobin, white cells and platelets. The red cell indices are extremely important. For me, after hemoglobin, if the hemoglobin is low, the most important thing is red cell indices. MCV is 50, which is low. MCH is 17, again low. Other cell lines normal. So basically, we can narrow down our differential diagnosis to a form of microcytic anemia. You do a blood picture, hyperchromic microcytic red blood cells, very non-specific blood picture, right? Nucleated red blood cells and few target cells. So we are dealing with a child with microcytic anemia who has hepatosplenomegaly and has a reasonably low hemoglobin. The differential diagnosis at this stage, if you consider the differential diagnosis of microcytic anemia, with the hepatosplenomegaly, thalassemia comes to as one of the most common or most likely diagnoses. Iron deficiency is unlikely with hepatosplenomegaly. Congenital sideroblastic anemia is a possibility. All these tally with that. Hematological malignancies or other things causing bone marrow invasion is unlikely because we clearly see a microcytic anemia and white cells and platelets are normal. So the 2 most likely differential diagnoses are thalassemia and congenital sideroblastic anemia. But it's quite rare for thalassemia to present at this age, 3 years without any transfusion. If at all, now we are probably dealing with a child with non-transfusion dependent thalassemia who has presented quite late in the sort of period. If generally thalassemia major will present within the first year of life, and when someone presents at 3 years or even after that, we have seen children presenting even at 7-8 years or even at teens with hepatosplenomegaly and with non-transfusion dependent thalassemia. So you think about non-transfusion dependent thalassemia, and the most important thing, investigation that you need to order in these sort of scenarios is a hemoglobin subtype quantification. That can be done by 2 methods. One is HPLC, hemoglobin high performance liquid chromatography, or hemoglobin capillary electrophoresis. What you see here are 3 reports of hemoglobin capillary electrophoresis, which is generally superior to hemoglobin HPLC. Just go through the reports. So these are the 3 possible reports that you might find in a child with non-transfusion dependent thalassemia presenting at 3 years. In the first report, you see HbA normal, HbA2 is high, 5.6. If the clinical picture is not with hepatosplenomegaly, this will be labeled as beta thalassemia trait. However, if this comes with a clinical picture of very low hemoglobin and hepatosplenomegaly, we need to consider thalassemia intermedia as the most likely possibility with this HPLC report. The HPLC in the middle shows HbF of 35% and HbE of 57%. And we don't see any HbA, and HbA2 is slightly elevated. So we have HbE, we have HbF. No HbA. So there's no normal beta globin gene. One gene, one allele is probably having HbE allele, and the other allele is probably having a beta thalassemia allele. So this report is quite compatible with hemoglobin E beta thalassemia. Thirdly, you have seen HbA, reasonable amount of HbA, but there's a P with the fast moving hemoglobin. So in the initial stages, and that we labeled as hemoglobin H, so which is compatible with hemoglobin H disease. So these are three possible HPLC reports or capillary electrophoresis reports of a child with non-transfusion dependent thalassemia. So non-transfusion dependent beta thalassemia. Non-transfusion dependent thalassemia can be either beta or alpha thalassemia. If it is beta thalassemia, it can be beta thalassemia intermedia, but the HPLC, you won't be able to distinguish it from beta thalassemia trait, or hemoglobin E beta thalassemia, or hemoglobin H disease. Right. So if we talk about each of these conditions, beta thalassemia intermedia, HbE beta thalassemia, hemoglobin H beta H disease, these are the non-transfusion dependent thalassemias that we commonly see. So what is this beta thalassemia intermedia? I know there's a lot of confusion, even among experienced clinicians, on this terminology. This term is generally not used because now we use the term non-transfusion dependent beta thalassemia. However, if we want to exactly tell what beta thalassemia intermedia is, it is an heterogeneous group of diseases. If you take the beta globin gene, you know there are two beta globin genes. There are only two possibilities that can happen. Either you have three possibilities. Either you have both normal two beta globins. In that case, you won't have any disease, you are normal. Or you can have a mutation in one beta globin gene, which is heterozygous beta globin mutation, and the HPLC will generally be of a beta thalassemia trait, as you see in this HPLC. If you have mutations in both the beta globin genes, you will have beta thalassemia major, and you have high HbF and no or very low HbA, as you see in this. With the clinical picture, you have to label each patient as beta thalassemia intermedia. So, if a child with beta thalassemia presents at the age after about 2 years, you consider them as non-transfusion dependent beta thalassemia. They can be any one of these conditions. So you may have a heterozygous beta thalassemia mutation. So only one beta globin gene is abnormal. However, you inherit more than two alpha globin genes in one chromosome. So you have excess of alpha globin genes. Your alpha to beta balance is shifted towards alpha. So there will be an excess alpha. Even with the heterozygous mutation, you manifest disease manifestations of beta thalassemia. On the other hand, if you inherit a favorable genetic mutation, even if you have homozygous beta thalassemia mutations, you might not present during the first year of life. So example is homozygous beta thalassemia mutation along with hereditary persistence of fetal hemoglobin. If you have this combination, If you didn't have a HP, hereditary persistence of fetal hemoglobin, you will be presenting in the first year, as for beta thalassemia male. Because of these mutations protect you from and give you higher HbF levels, you present quite late. The other scenario is you have milder beta thalassemia mutations in homozygous level. Example is what is known as delta beta thalassemia. I'm not going to go into detail on this mutation. So that is what is meant by beta thalassemia intermedia. The other condition that we are going to talk about is hemoglobin E beta thalassemia. I'm sure this is quite clear to most of you, but if you are very unclear, the hemoglobin E mutation is a specific mutation, a point mutation which you see in the beta globin gene, which is quite similar to thalassemia mutation but not equal. So there are several possibilities that can happen with the hemoglobin E mutation. You can be heterozygous for hemoglobin E mutation, which is known as hemoglobin E trait. And if you are hemoglobin E trait, you will be perfectly asymptomatic, exactly similar to beta thalassemia trait. In rare instances, you can be homozygous for hemoglobin E. So then you have what is known as hemoglobin E disease. Again, is not a severe form of thalassemia. What we commonly see in Sri Lanka is the compound heterozygous state of hemoglobin E mutation along with the beta thalassemia mutation. In one beta globin gene, you have hemoglobin E mutation, and in the other, you have beta thalassemia mutation. Because there is a beta thalassemia mutation, you don't have any alpha globin. This gene will produce hemoglobin E, as you see here, and this gene will produce hemoglobin F because the beta globin is inactive in that chromosome. So you have HbE and HbF. That is known as hemoglobin E beta thalassemia. This is quite common in Sri Lanka. I'm sure you have seen several patients with hemoglobin E beta thalassemia. The other possibility is for non-transfusion dependent thalassemia is a non-transfusion dependent alpha thalassemia. As you know, there are 2 alpha globin genes in each chromosome. If you have all 4 alpha globin genes, you are normal. Absence or mutation in either 1 or 2 is generally asymptomatic, and you will be known as, you will have a very asymptomatic microcytic anemia, which is known as alpha thalassemia trait. If all 4 alpha globin genes are mutated, then what you end up with hemoglobin Bart's hydroxyurea, which is generally not compatible with life. If you see in a 3-year-old child with hepatosplenomegaly and microcytic anemia, the possibility is deletion or mutation of 3 alpha globin genes, giving rise to hemoglobin H disease. Hemoglobin H disease can be also diagnosed by requesting hemoglobin H inclusion bodies in the peripheral blood. As you see here, there will be appearing as golf ball. This is known as golf ball appearance. These are the hemoglobin H inclusion bodies. Specialized states. HPLC or capillary electrophoresis can sometimes detect hemoglobin H, but not always. So this is not a representative HPLC. This shows very high HbH levels, but generally we don't see this. However, HPLC can also detect HbH if you see HbH band, and you can make the diagnosis. But the definitive way of making the diagnosis of hemoglobin H disease is through genetic analysis, mutation analysis to demonstrate mutations in both the alpha globin, both chromosomes. Right, so these are the 3 conditions that gives rise to non-transfusion dependent beta thalassemia. Whatever the cause, the treatment or the management is generally the same. Whether it is beta thalassemia intermedia, whether it is hemoglobin E beta thalassemia, which is milder, or whether it is HbH disease. Generally, we don't commence them on regular transfusions. We assess the need for transfusion in individual basis. I must say that some patients with hemoglobin E beta thalassemia might not fit into the category of non-transfusion dependent thalassemia, so they may be managed as transfusion dependent thalassemia by respective consultants. That is also possible. But if they are non-transfusion dependent thalassemia, you aim to maintain a hemoglobin around 6 to 7 grams per deciliter without transfusing them. We are not aiming for a HB of 9 grams per deciliter in these children because we are avoiding transfusions as much as possible to avoid iron overload. Transfusions are individually decided. If they are symptomatic, you have to transfuse. If they is associated with growth failure, yes. If there are severe facial features, you might consider transfusing, and if there is a rapidly enlarging plate. However, hemoglobin per se is not an indication for transfusion in children with non-transfusion dependent thalassemia. What about iron chelation? Iron chelation is quite similar to transfusion dependent thalassemia. However, there are several differences. The drug choice is similar to transfusion dependent thalassemia. In our unit, we start all children with oral iron chelator deferricetic, even at very low age. The dose is generally lower in non-transfusion dependent thalassemia. Even low as 10 to 20 milligrams per kg of deferricetic can be used. Normally, the dose for transfusion dependent thalassemia is 20 to 40 milligrams per kg per day. In transfusion-dependent thalassemia, we commence iron chelation when ferritin rises more than 1000. However, in the non-transfusion-dependent patients, the recommendation is to start iron chelation when ferritin starts more than goes beyond 800. If you are not transfusing these children, the ferritin might come down. When it comes below 300, you can stop iron chelation. Another drug that has shown to have some promise in non-transfusion dependent thalassemia is hydroxyurea. Now, at present, we have completed a trial with hydroxyurea on transfusion dependent, and certain amount of patients have shown some improvement with hydroxyurea. However, when it comes to non-transfusion dependent thalassemia, hydroxyurea is recommended. The dose of hydroxyurea is 10 to 20 milligrams per kg per day. What it does is to improve the fetal hemoglobin production, and so it's useful in beta thalassemia intermedia and HBE beta thalassemia. However, it is not useful in hemoglobin H disease, where increasing gamma globin will not be very useful. Folic acid should be given to all patients with non-transfusion dependent thalassemia because their bone marrows are anyway working hard. They will be in a state of chronic anemia. For transfusion dependent thalassemia patients, we generally do not give folic acid. It's not recommended. It has been a routine treatment modality for non-transfusion dependent thalassemia. However, the current consensus is not to do routine splenectomy. So the indications for splenectomy in non-transfusion dependent thalassemia is very limited. If the platelet count and white cell count persistently low due to splenomegaly, hypersplenism, then there's no other way that you can improve the platelet count. You have to go ahead and do splenectomy. If the spleen is very large, the massive splenomegaly is defined as spleen more than 20 centimeters, then you might consider doing splenectomy because there's risk of injury. So those are the management options for non-transfusion dependent thalassemia. Blood transfusions, individually decided, iron chelation, folic acid, hydroxyurea, and splenectomy if indicated. There are several long-term complications of non-transfusion dependent thalassemia, which are not seen in children with transfusion dependent thalassemia. And these are long-term complications. As pediatricians, we will not see them. However, in adults, these are common. They can also have iron-related complications. However, venous thrombosis, pulmonary hypertension, leg ulcers are specific complications that are seen in adults with non-transfusion dependent thalassemia. So that's basically about the management of non-transfusion dependent thalassemia. Case number 2. A 10-year-old boy who is diagnosed with sickle beta thalassemia and has presented with right-sided arm and leg weakness. How common is this in Sri Lanka? And is it possible for you to see a child with sickle beta thalassemia during your exam, or can they come as a case history source? Answer is true. This is a recent paper published by Professor Anuja Premawardana, and they have evaluated almost all patients with sickle cell disease in Sri Lanka. It's very rare, however, it's not unseen. So, according to them, there are about 60 patients with sickle cell disease in Sri Lanka. 9 of them has sickle cell anemia, and 51 has sickle beta thalassemia. I will tell you the difference. And they are clustered in 2 areas. A large majority are in Kurunegala and Anuradhapura area where thalassemia is commonly seen. However, we have seen a large cluster of sickle cell disease patients in the Hambantota Monaragal area in this cluster. Also, there are few in Batiklo, Trincomalee, and in isolated area. So there are about 60 patients with sickle cell disease in Sri Lanka. They may not be all children. So what's the difference between sickle cell anemia and sickle cell disease? So sickle cell disease is generally considered all these scenarios. It is diagnosed by HbA1c. If you are normal, your HbA will be more than 95%, and you will not have any HbF less than 2%. If you are heterozygous for sickle cell disease mutation, which is known as sickle cell trait, you have about 20 to 40% HbS, but the majority of hemoglobin will be HbA, 50 to 70%, and HbF is normal. If you are homozygous for sickle cell mutation, which is a point mutation, you can't have HbA unless transfused. And most of your hemoglobin will be hemoglobin S, 80 to 95%. However, you will have a slightly higher HbF level. The common scenario is we see out of 60 patients, sickle beta thalassemia. Here has sickle cell mutation, whereas the other allele has beta thalassemia. Because the beta thalassemia mutation will not be able to produce hemoglobin at the same rate as sickle allele. Generally, more than 50% of hemoglobin will be HbS. So 50. Depending on the severity of your beta thalassemia mutation, you will know whether there will be HbA. Means there won't be any beta globin production from that, then there won't be any HbA. However, if the beta thalassemia mutation is a beta plus or beta plus plus mutation, there can be low amount of hemoglobin. Whatever the condition, your HbF will be generally around 20%. So you have high more than 50% HbS and more than 20% of HbF. It's likely to be sickle beta thalassemia. Whereas in sickle cell anemia, 80 to 90% of your hemoglobin will be HbS and HbA will be absent. Right. So sickle beta thalassemia is the common disease in Sri Lanka. So it's a combination of sickle cell disease and beta thalassemia. However, the clinical picture, problems and management, everything is quite similar to sickle cell anemia rather than to thalassemia. So sickle beta thalassemia is generally managed as sickle cell disease and not as beta thalassemia. So what's the pathophysiology of sickle cell anemia or sickle cell disease? So when you have this genetic mutation, point mutation, it causes polymerization of the hemoglobin S. So there are two main pathophysiological mechanisms. This polymerized HbS can make your erythrocyte sickled or elongated, and those erythrocytes can cause vaso-occlusion. There are several mediators of vaso-occlusion, including endothelial cell activation, vasoconstriction, platelet activation, inflammatory response, neutrophil adhesion, However, main problem will be vaso-occlusion, and because of that, there will be ischemia to the tissues. At the same time, this polymerized HBS can cause erythrocyte membrane damage. Because of that, there will be an early or premature destruction of red blood cells, hemolysis, which can lead to anemia. However, the anemia is not as severe as in thalassemia. So the most problems with sickle cell disease, either sickle cell anemia or sickle beta thalassemia, is due to vaso-occlusion. Anemia is less of a problem. Generally, these patients will maintain a hemoglobin of around 7 to 8 grams per deciliter without transfusion. So regular transfusions are generally not given to patients with sickle beta thalassemia. They will manifest all the clinical features that a sickle cell disease patient can have. So this is a summary of clinical manifestations or problems of sickle cell disease patients in Sri Lanka. Joint pain due to vaso-occlusion is common. So this concentrate on the last column. This shows sickle beta thalassemia patients, and this column shows sickle cell anemia patients. However, there are no major differences, so concentrate on the last column. So about 65% has had joint pain. Splenomegaly is not always there. It's a well-known fact that the spleen goes autosplenectomy, or spleen becomes very small with time in children with sickle cell disease because of the infarctions. However, at the early stages, you can have a palpable spleen. Although the spleen is palpable, that is non-functional. So you have functional spleen. So 60% had palpable spleen, 48% had jaundice, and infections are quite common with these patients, and generally osteomyelitis, pneumonias, these are common. Dactylitis is another common presentation, which is due to vaso-occlusion generally. Gallstones are also seen in sickle beta thalassemia patients. Acute chest syndrome, cough, fever, severe shortness of breath, combination of infection and vaso-occlusion is seen in 13%. And strokes have been seen, I don't know whether it's about in quite certain percentage will have ischemic or hemorrhagic strokes. So those are the clinical features in sickle beta thalassemia. How would you manage a child with sickle beta thalassemia? What are the management options? So it's exactly similar to management of sickle cell anemia. These children are generally not given routine blood transfusions. However, several medications will be helpful in the management. Hydroxyurea is recommended to all children with sickle cell disease. The aim of giving hydroxyurea is to increase the HbF level and to reduce the HbS percentage. And the dose is 10 to 20 milligrams, and you can go even up to 35 milligrams per kg per day. There will be continuous hemolysis and excess erythroid production, so folic acid is recommended daily. Because these children can have autosplenectomy, they are prone to infections with encapsulated organisms. Lifelong penicillin prophylaxis is recommended. And immunization against pneumococcal, meningococcal, and Hib by vaccination is recommended. So those are the general management things that are done for children with sickle beta thalassemia. Hydroxyurea, folic acid, penicillin prophylaxis. Most patients, almost all, will not require regular transfusions, and they will maintain a hemoglobin around 7 to 8 grams per deciliter, or maybe even higher. However, if you transfuse, it will reduce the hemoglobin S percentage because you will be giving blood with hemoglobin A and reduce the vaso-occlusion. Transfusions are indicated in two scenarios. There are instances or indications for acute therapeutic transfusions when they develop some complications of sickle cell disease. Certain complications of sickle cell disease can indicate chronic regular transfusions. So when you consider giving a blood transfusion or acute therapeutic transfusions for an acute illness to a child with sickle beta thalassemia, if the child has symptomatic anemia with low hemoglobin, you have to give transfusion. Acute stroke, acute chest syndrome are indications of blood transfusion. Here, the aim is to reduce the HbS percentage to less than 30% to reduce the vaso-occlusion. So in stroke and chest syndrome, the aim of transfusion is not only to increase the hemoglobin, which is not the primary aim. Primary aim is to bring down the hemoglobin S percentage to less than 30%. Remember, children with sickle beta thalassemia will generally have HbS of more than 50%. By giving blood transfusions, you give HbA and the HbS percentage will come down. And aim is to bring it down to 30% while keeping the hemoglobin about 10 grams per deciliter. So when you are managing sickle beta thalassemia patients, it is generally required to have HPLC available on site or in close proximity. If the HPLC or capillary electrophoresis report takes a month for you to get, generally that is not a best place to manage sickle beta thalassemia patients who need acute care. They are prone at developing acute aplastic crisis and splenic sequestration. In both these scenarios, the hemoglobin will drop drastically to low levels. Then you have to transfuse to bring the hemoglobin to a reasonable level of more than 10 grams per deciliter. We are not aiming at 14 here. Bring the hemoglobin to more than 10 grams per deciliter. So those are the indications for therapeutic acute transfusions in sickle beta thalassemia. If a child develops a stroke, ischemic stroke, then a child with sickle beta thalassemia should be put on chronic regular transfusions to maintain the HB more than 10 grams per deciliter and HbS less than 30%. This is to prevent stroke in the future. So, chronic transfusions are indicated as secondary prevention of stroke in a child with sickle beta thalassemia who developed stroke. Again, if you have pulmonary hypertension, chronic regular transfusions are indicated. The management of complications of sickle beta thalassemia are quite similar to management of complications of sickle cell anemia, which you can read from any standard textbook. The vaso-occlusive pain is managed with hydration and analgesics, leg ulcers, wound care, compression bandages, sepsis and meningitis with good high-dose antibiotics. Acute chest syndrome involves hydration, analgesia, might require respiratory support, antibiotics, bronchodilators, and transfusions. Ischemic stroke, hydration and transfusion. Hemorrhagic stroke, you might consider neurosurgical intervention. Dactylitis, hydration, analgesics. Avascular necrosis of the hip is a known complication of sickle cell disease. Again, the management options are hydration, analgesics, and maybe later on orthopedic opinion. Likewise, so these complications should be managed. You can read about these in whatever the standard textbook. Right, that is the management of sickle beta thalassemia. Now we are moving to the last case. So don't worry, I won't be talking too long, maybe another 5 to 10 minutes. A 3-year-old boy who was incidentally detected to have anemia. So now the child is quite perfectly normal. For a viral illness, you have done a full blood count and the hemoglobin is low. He is perfectly normal except for pallor. There's no hepatomegaly, no splenomegaly. The full blood count shows quite a low hemoglobin, 6.5. And the red cell indices are also low, 50 and 70, MCV 50, MCH 70. Other cell lines are normal, right? So there's no hepatomegaly, no splenomegaly, but very severe hypochromic necrocytic anemia. We know the differential diagnosis at this point includes iron deficiency anemia, thalassemia trait. So you do a serum ferritin, which comes as low, 2. Serum ferritin is 2. Serum ferritin less than 15 is generally considered as low. So iron deficiency anemia is the likely diagnosis. You start treatment with therapeutic dose of iron, 6 mg per kg per day, iron for 1 month. After starting iron treatment, it's a must to follow these children up and do a repeat full blood count after a month to see whether they have shown a response. Surprisingly, hemoglobin is still 6.4. So there's no response to treatment dose of iron. You may do it for another 1 month, considering that the compliance is not good, but still it's quite low. So what are the possibilities? There can be two possibilities in this scenario. One is this child may be having a chronic blood loss or maybe malabsorption syndrome to give rise to iron deficiency, which is not responding to iron. However, if once you exclude malabsorption, chronic blood loss, and poor compliance, it can be a patient with iron refractory iron deficiency anemia, which is not that rare. So iron refractory iron deficiency anemia is a genetic disease of iron metabolism, which leads to severe hypochromic microcytic anemia with hypoferrinemia, right? Low serum ferritin. So in this child, the thalassemias are not in the differential diagnosis because thalassemia will generally give rise to high serum ferritin. HBH disease is not in the differential diagnosis. You do an HPLC will be normal, but still alpha thalassemia does not come into the differential diagnosis because the serum ferritin is low. Iron refractory iron deficiency anemia is due to a mutation in a specific gene which is known as TMPRSS6 gene, TMPRSS6 gene, which encodes for a protein known as maltryptase, right? What it does is to inhibit the hepcidin production from the liver. We know hepcidin is the master regulator of iron metabolism. When we have this TMPRSS mutation, the hepcidin inhibition is reduced, so there will be high levels of hepcidin produced from the liver. We know hepcidin will inhibit the iron absorption from gastrointestinal tract as well as iron mobilization from the spleen. So duodenal absorption of iron is decreased by high levels of hepcidin, and splenic iron released into the circulation is also decreased by hepcidin. So genetic mutation will lead to high levels of hepcidin, and high levels of hepcidin will give rise to reduced absorption. Even if you give iron, that iron will not be absorbed. So there's no iron deficiency, and there's a problem with iron absorption. Features of iron refractory iron deficiency anemia are similar to features of severe iron deficiency, severe microcytic anemia, low serum ferritin, low plasma iron, and generally very low transferrin saturation, less than 5%. The cardinal feature is no improvement with adequate doses of oral iron. However, I remind again, chronic blood loss and malabsorption should be excluded. To make a definitive diagnosis, a genetic mutation analysis by sequencing the TMPRSS6 gene should be done, and that will confirm the diagnosis of iron refractory iron deficiency anemia. Once you have made the diagnosis, the treatment is a bit difficult, not very straightforward. You can try high doses of oral iron, which we have tried. We have one patient with iron refractory iron deficiency anemia, and he has responded to high doses of oral iron. Parenteral iron again is not superior to oral iron. You can try. However, the utilization of parenteral iron again needs the splenic action of iron release, so that might not work. If you are unable to increase the hemoglobin with these two maneuvers, these children might require blood transfusions, regular transfusions. However, it is known iron refractory iron deficiency anemia to improve gradually with time. So when they get older, the iron requirement of the body is low. So the iron deficiency and iron deficiency anemia improves a bit. I think we have come to the end of the presentation now.